Hello and a very good afternoon, everyone. I hope you all are doing well. Today's Master Series session is on management of TBI, which is traumatic brain injury, which is a global health issue leading to millions of deaths and disabilities every year. For this, we have with us Dr. Shrikant Sahasrabudhe. Welcome, sir.
Hello.
He's the director and HOD of the Department of Critical Care and Pulmonology at Medicover Hospitals. Dr. Sahasrabudhe is a gold medalist in MD from Mumbai University and has also received the award for excellence for outstanding contribution to critical care medicine in India, conferred by ISCCM in the annual Critical Care Conference in Varanasi back in 2018. He has 18 years of experience as a director of ICU and pulmonology in Kamal Nayan Bajaj Hospital in Aurangabad and has several publications in peer-reviewed journals as well. His areas of expertise are central line, arterial line, percutaneous tracheotomy, difficult intubation, IABP, etc. So it's a pleasure to have you with us here. Please go ahead and please deliver the talks.
Yeah, thank you very much for the kind words. And without any further ado, I think I'll start my talk for today. Good afternoon, everyone. It's very difficult to kind of listen to any academic session post lunch, but I'll try to make it as interactive and as informative as possible. The topic of my talk today is traumatic brain injury, especially the ICU management. As you could see that any neurological emergency as such would be probably divided into medical and surgical, and there you can see the whole lot of list of the medical emergencies, and that is probably not in our scope of discussion today. But we are primarily talking about the traumatic brain injury, which is in the form of either the subdural hematomas or extradural hematomas or intracerebral hematomas or subarachnoid hemorrhage and so on and so forth. Now, as has been discussed, this is a global problem. And again, as we know that the data usually comes from the West, especially from USA, as you could see, it's the second leading cause of death and third leading cause of disability, predominantly related to the subarachnoid hemorrhage and hypoxic ischemic encephalopathy. Now, what exactly happens here, as you could see on the right side of the slide, is there is release of these cytokines and the inflammatory and the pro-inflammatory cytokines, which leads to the death of the neurons in the brain. And that is what is probably important whenever there is any hemorrhage, any kind of hemorrhage inside the brain. So pathophysiology of traumatic brain injury is complex and multifactorial, and there are several components of the key importance for us to understand. Usually there is reduction in the substrate delivery below the critical thresholds, and there is a failing cellular metabolism. Basically, it is related to the inability to utilize the delivered oxygen and glucose, and that is the most important pivotal kind of ingredients for any metabolism to start with. And eventually it leads to cerebral ischemia and hypoxia. So this is the pictorial kind of depiction of the same, where you have more the metabolic crisis, the outcomes are bad. And if you have the baseline, then the outcomes are relatively good. And as you could see that these slides, which actually depicts about the delivery of oxygen, which in turn is dependent upon the cerebral perfusion pressure. As you could see that the neuronal injury or neurological injury is either could be primary, which is not in anyone's hand, especially in cases of trauma, and secondary injuries, which are predominantly, we will come to that, but it's predominantly hypoxia and hypotension. So these are the two main secondary injuries, and this is what we need to target. The three main priorities for any treatment of TBIs would be resuscitation, and as I said, hypoxia, so adequate oxygenation, hypotension, so adequate mean arterial pressure. Second is to prevent herniation of the brain, and of course, the rapid diagnosis of the brain lesion as to what it is and what needs to be done. So for example, if it is extradural hematoma, It is more emergent situation than subdural, where it needs a surgical correction than subdural, and subdural can wait. So coming to this part of the slide, which you can see that basically it is the lungs gets affected secondarily, where as you can see that there is less oxygen and increased production of carbon dioxide because of hypoventilation. So hypoxia in turn will give rise to decrease in the delivery of oxygen, and it secondarily affects the CPP, that is cerebral perfusion pressure, and eventually it leads to less of CPP inside the brain, more of the ICP, and more and more of ischemia, reperfusion injury, and so on and so forth. So this is the main cascade which anyone needs to kind of remember. So the primary injuries and the secondary injuries, where you can read it for yourself, but it's mainly the primary injuries related to the mechanism of the head injury. Either it could be the skull lacerations, fractures, contusions, and diffuse axonal injury. Whereas secondary injuries, where we have already discussed hypoxia and hypotension, predominantly, followed by hypothermia, electrolyte disturbances, oxygen radical injuries, and increase in the ICP, which we just now discussed. On the top of that, we need to be very careful of these three conditions: hyperthermia, which is very bad for the brain, seizures, and hypo and hypercarbia. And we talk of TTM, as somebody would actually know, that is targeted temperature management, especially in patients of TBIs, where we know that hyperthermia in any case is deleterious to the brain. So we need to target either hypothermia or normothermia. Now, these are the prevention of the secondary insults, and we talked of that. We just talk of the hypoxia and hypotension, and as you could see that the more the ICPs, lesser will be the CPPs, and there will be more morbidity and mortality. So this was one of the US traumatic coma data bank, and which looked upon about 770 odd patients. There they had about 45% of the patients had hypoxia and or hypotension, where it was clearly shown that it will increase the morbidity and mortality of the patient. Early detection will have a better outcome, and this was a paper from Steen et al. Another paper which showed that early intubation, or the early airway protection, which is based upon Glasgow coma scale. So if there is a better Glasgow coma scale in the first 6 months, there are more favorable outcomes. As far as treatment modality was concerned, they had actually compared hypertonic saline versus normal saline, and this particular paper from JAMA 2010 had shown no evidence of hypertonic saline being beneficial, and we will come to that a little late. So these are the consensus guideline, and most of my talk or evidences have come from Brain Trauma Foundation, which is a very standard document, and I would definitely appeal and recommend for the viewers to read Brain Trauma Foundation related document for the recent management guidelines on traumatic brain injuries. So we have some ABG targets, that is, we know that we should avoid hypoxia. We have the cardiovascular targets in the form of mean arterial pressures. We have targets in the form of sugar control, temperature control, so that the ICP should be less and the CPP should be at least between 50 to 70. So as I said, it is Brain Trauma Foundation, and they get updated every 5 years or so. So our targets are 7 normals. So these are the these are the parameters which we aim for the normalcy: normal oxygenation, normal carbon dioxide, normal volumia, normal blood pressure, normal temperature, normoglycemia, and normosmolality. So this is pretty easy to understand. So we obviously need to investigate these patients in the form of blood tests, and we send a whole array of these blood investigations, especially the coagulation parameters also, along with the CPK, to know whether there's chance of rhabdomyolysis in future. And of course, imaging in the form of X-rays, sonography, CTs, and MR. Remember, coagulopathy is very common in patients with severe traumatic brain injury. You need to take control of ABC. So A is airway, and as we know that whenever there's a Glasgow Coma scale of 8 or less than 8, you need to intubate this patient. You may take help of something called as a rapid sequence intubation. That is, if the patient has difficult intubation with the use of fast-acting muscle relaxants or cricothyroid pressure until the intubation happens. We need to actually even consider bronchoscopic intubation in the setting of difficult airway or suspected cervical injury. Again, as you could see, and I will repeat, maybe there would be some repetition, and Brain Trauma Foundation. And the last updation which I found was September 2016. So ABC, we start with airway, opening of the airway with the help of modified jaw thrust and not the routine jaw thrust, especially with a suspected cervical spine injury. We need to administer high flow oxygen, bag mask ventilation whenever required, and most comatose patient needs intubation, which is performed by a experienced operator. As far as, so we had A, B, and now C. For circulation, the target mean pressure of about 80 to 90 to maintain adequate CPP. Shock, remember that, which is rarely due to result of a head injury. So whenever you have a shock patient, in a case of traumatic brain injury, always think of something else apart from head injury, and we'll come to that what are the other causes of shock. So these are few trials where they have said that there is no level 1 recommendation for this, and level 2 recommendation was BP should be monitored. So invasive arterial line has to be put in the patients whom we target mean arterial pressure of about 80 to 90, and hypotension has to be avoided. Again, level 3 recommendation for oxygenation monitor and hypoxia should be avoided. So these are the few evidences for circulation or mean arterial pressure. Again, talking about indications for ICP monitoring, again, there were about 21 trials which looked upon the level 1 recommendation, which suggests that there was insufficient data. Whereas in level 2, you have monitoring for all salvageable patients with severe TBI, Glasgow Coma scale between 3 to 8, where we have a post-resuscitation care, and abnormal posturing, like you could see that this is a decorticate and this is a decerebrate posturing. Whereas in a severe TBI, where we have, the level 3 monitoring, where you have, this is a recommendation of level 3 monitoring in the patients with severe TBI or with normal posture, but the age of more than 40 and SBP of less than 90. So any patient who is having hypotension, we need to actually monitor ICP. Now, these are the different methods of monitoring of ICP in the form of ventriculostomy, intraparenchymal catheters, epidural transducers, subdural catheters, subdural bolts, which are reasonably common. And we have actually just now discussed the evidence or what is the standing of ICP monitoring at the present point in time. And these are the criteria for exclusion for ICU monitoring. So patients with bilateral unreactive mydriasis or bilateral dilated pupils, untreatable lesions at CT, so very bad CT scan, very advanced age, comorbidities, extracranial lesions which are difficult to manage, coagulopathy and Glasgow Coma scale. To start with, if it is less, say 5 or more than less than 5, we need to actually rule out the ICP. As we know, CPP, the formula is mean arterial pressure minus ICP, and the normal CPP which needs to be maintained is around 50 to 70. So with that, the MAP becomes a target between 70 to 90. So the ICP treatment threshold should be of more than 20 millimeters, and that is where the problem starts. There is a concept of autoregulation. So if that is intact, then cerebral blood flow, so CBF stands for the cerebral blood flow, which is maintained between the mean blood pressure of 50 to 150. In moderate to severe brain injury, the autoregulation is impaired. So cerebral blood flow varies. So this is what the graph shows, that the moment autoregulation gets disturbed, the cerebral blood flow also will get disturbed. And that is what the essence of that slide was. Now, these are the few recommendations again for the CPP thresholds. So there's insufficient data again to have a level 1 recommendation. But as far as level 2 recommendation, they have said that you avoid CPP of more than 70. You need to maintain CPP of around 70 with either IV fluids or vasopressors, and you need to be very careful or vigilant about the dreaded complication of ARDS in these patients. The level 3 recommendation is avoid CPP of less than 50, which is very clear, because then the cerebral blood flow will also decrease, and the CPP of between 50 to 70 is safe. Okay, so with a good auto-regulation and the CPP elevation, there could be a better outcome. And the defective auto-regulation, but the CPP which is lower, then there may not be a better outcome. This is what the Brain Trauma Foundation says. Now, management of raised ICP in cases where the surgical intervention is required, the patient undergoes a surgical intervention. We need to actually consider mannitol, 3% saline, which we will discuss. Optimization of the venous drainage. So always keep the neck in a neutral position, and that is very important practical point. Don't tie or don't do the dressing of the CVP very tight. Don't tie the endotracheal tube very tight so as to have a good venous drainage. And sedation, of course, forms the important part. Now, what are the evidences for decompressive craniotomy? And level 1, again, there is insufficient data. Whereas level 2A, it says that the diffuse lesion and ICP of more than 20, bifrontal decompressive craniotomy, which is not recommended. Whereas it is said that when the ICP decreases, it will decrease the length of stay in ICU. But then this has actually said that bifrontal decompressive craniotomy may not help. A large frontotemporoparietal decompressive craniotomy, which is recommended for the lesion not less than, so 12 into 15 centimeters or 15 centimeter diameter. So this is the probably the size of the bleed which will guide us and probably tell us that the decompressive craniotomy may help. Now, talking about cerebral edema, as we know that it can kill the patient. So mortality can be as high as about 50%. So we are talking about osmotherapy here, and this is a medical therapy for the traumatic brain injury and the cerebral edema, which is associated with the same. And we have two agents, the famous mannitol and the hypertonic saline. So the dose of mannitol, what is the peak action duration, we'll discuss. So it is 20% mannitol, and the dose which is 1 gram per kg. So it is about 0.25 to 0.5 grams per kg, given the frequency of 6 to 8 hourly IV. Okay, so what mannitol does is it will take the edema fluid from the neuron or from the cell and will push that inside the vessel. So intravascular volume may increase, and it can actually give rise to pulmonary edema sometimes. Okay, that needs to be very, very carefully monitored. At the same time, it can actually cause the second action of the mannitol. It will actually give rise to fluid overload, as we have actually just now discussed. So the action starts within few minutes, and it can actually peak within an hour, and the action may last for about 4 to 24 hours. The things which needs to be monitored for the patients on mannitol are serum sodium. Be careful if it is going above 150. Serum osmolarity, be careful if it is going above 320. And of course, renal function tests, and look for the ATM. So these are the three probably the indicators or the signals I'm sorry, to look for when the patient is on mannitol. So these are the benefits of the osmotherapy. There is shrinkage of the brain, which is depicted in this particular diagram. There is shrinkage of the RBC, so it will get less rigid and it less cohesive. So there will be definitely the problem which can happen sometimes with the overtherapy of mannitol. We have seen that it can lead to decrease in the CSF production, and in turn it can actually have increase in the volume, in the intravascular volume, decrease in the viscosity of the blood, and it can eventually lead to decrease in the ICP. So these are the few of the benefits of the osmotherapy as we are talking about. There could be a rebound cerebral edema with mannitol, which is seen after some time. There is a possibility that the intravascular fluid can be actually again kind of sucked inside the cell, and that is what the problem is. And the duration of mannitol and monitoring of these three parameters, including the serum sodium, osmolarity, and the renal function tests, are so very important. So what are the side effects of mannitol? It is mainly, as I said, there could be rebound increase in the ICP, which I just now discussed. There could be pulmonary edema. There could be hemolysis, because the shape of the RBCs can actually vary, and it can decrease or it can shrink. And AKI, So remember, AKI, pulmonary edema, rebound cerebral edema, and problems related to RBC. Of course, we can't forget sodium, hyperkalemia, hypomagnesemia, and hypophosphatemia. So is there any evidence that has shown the beneficial outcome in giving osmotic therapy? So there was no conclusive outcome benefit, and the benefit which was transient decrease in the ICP, and harm, of course, was rebound increase in the edema, electrolyte disturbances, which we just now discussed, pulmonary edemas, and AKIs. Talking about hypertonic saline, and as we know that we are talking about mannitol all this time, and now we need to actually kind of embark upon hypertonic saline also. So what it causes is, if you give bolus versus continuous infusion, it has been shown that bolus is always better, and it will take out the excess of fluid from the cell inside the vessel in a more efficient manner if you give it as a bolus, as compared to infusion, which can cause a sustained hyperosmolar state, and then eventually the cell size returns to normal. But remember that hypertonic saline bolus is probably preferred, and this is what the evidence is. If you actually look at the control of ICP, you can see that the all these studies or the trials which has been shown on this slide will favor sodium as compared to mannitol. Mean quantitative decrease in the ICP, again, the couple of trials or the studies will favor sodium as compared to mannitol in terms of decreasing in the ICP. And hypertonic saline versus mannitol for the treatment of raised ICP, and this was a meta-analysis of the randomized controlled trials, which has been shown time and again that hypertonic saline is a slightly preferred agent as compared to mannitol. So in summary, if you see the summary of the studies, the hypertonic saline favoring studies are about 6, as have already shared. So there's balance which is slightly tilting towards hypertonic saline. Mannitol favoring study was just 1 in what the literature which actually I looked upon, and the meta-analysis which favored hypertonic saline. So in conclusion, they have said hypertonic saline is more effective than mannitol in reducing ICP, in improving CPP, and improving the hemodynamics as compared to mannitol. But yes, larger studies are needed to ascertain the effect of HTS on functional outcomes and the survival of the patient. Now, what is the role of prophylactic hypothermia? There are about 6 trials, again, in Brain Trauma Foundation. Level 1 recommendation, there is insufficient data. Level 2 recommendation, again, there is insufficient data. But a level 3 recommendation, which compared normothermia versus hypothermia, which clearly showed that there's a decrease in the mortality if the temperature is kind of targeted for about 48 hours after the traumatic brain injury, and we maintain the temperature in the range of, say, 33 to 35 degrees Celsius, if I can remember correctly. So this is again about the body temperature and the brain temperature and the neuroprotection. As you could see that in the stage 1, you have ICP of more than 20. In the stage 3, you have decompressive surgery or use of barbiturate. Whereas you could see that the osmotherapy plus sedation, which was instituted in the 2nd stage, and you could clearly see that this particular, the worst outcome, if you see the odds ratio, which favors the hypothermia in this particular favor. So you have a favorable outcome in about 26% of patients who underwent hypothermia or targeted temperature management. Here the temperature range which I just quoted about 33 to 35, where this is given as 32 to 35, whereas it was about 37% in the other patient group or management group which did not institute the hypothermia. So it was clearly, this paper actually clearly says that we need to protect the brain in terms of temperature. Now, this is another paper which talks about the brain temperature. As you could see that how it can mitigate this cerebral edema and the threats related to the increased ICP, where we want the less ICP. There were about 37 randomized control trials, which shows that mild to moderate decrease of the temperature to the tune of 32 to 35 degrees showed no benefit. In fact, so this is probably a negative study, which shows that there could be a risk of pneumonias, especially the aspiration pneumonias, and there could also be, decrease in the kind of platelets. Sometimes you can have thrombocytopenia or coagulopathy. So these are the two major side effects of hypothermia, which was shown in this particular paper by Polderman et al. What about anti-seizure prophylaxis? Level 1 is insufficient data, and level 2, which talks about phenytoin or sodium valproate. These are the standard two agents which are given, which will decrease the post-trauma seizures for about 7 days. And if there are early post-traumatic seizures, then it talks about the worst outcome for these patients. So they are not recommended. These agents are not recommended probably for the prevention of the late PTS, but more importantly for the early PTS. What about analgesia, analgesics, anesthetics, analgesia, and sedatives? So you have level 1 and 2A, which is insufficient evidence. Level 2B talks about barbiturate, but again, it is not recommended. High dose barbiturates, which actually have been used and instituted for raised ICP, refractory to medical and surgical therapies. And for propofol, they are not found to improve 6 months mortality. So eventually, you can see that there is no particular agent which has been kind of recommended. And these are the common sedatives and analgesics which we use in ICU, be it be fentanyl, and these are the doses. I think you can read it for yourself. Fentanyl, midazolam, and propofol. So these are the three probably very, very important agents which we try and use for these patients in our ICUs. What about CSF drainage? Again, level 1, 2, there is insufficient evidence. Level 3, there is EVD system, which is continuous drainage, then intermittent, which can be considered. So continuous drainage is probably, if at all someone asks you, there could be continuous drainage, and lower ICP in GCS of less than 6 during first 12 hours, which can be considered. Steroids, there's definite no, and as we know that the methylprednisolone can cause high mortality. These are the few advanced neuro monitoring modalities, including jugular venous oximeter, brain tissue oxygen tension, cerebral microdialysis, and thermal diffusion flow meter. And this depends upon the protocol of the each and respective ICUs, where you really kind of utilize these measures to kind of use it in your daily practice. So these are the different modalities which we just now discussed: the cerebral, microdialysis, and the PbO2 and SjVO2, which aids in the selection of best CPP. And of course, I think probably these are, I'm coming to the end of this, where we need to be very sure of our standard ICU care, and please don't kind of compromise or be complacent in giving the standard ICU care to any TBI patient, including the use of ventilatory care bundles, early tracheostomy, which has been shown to reduce ventilator days, the sedation and the pulmonary complications, and of course, the ICU length of stay. Nutrition has to be spot on. Bowel care needs to be done in a correct fashion, an ideal fashion. Infection control measures at all times, care of arterial lines and the central lines, of course, along with the ICP monitors or the drainage of the CSF, if at all it is done. de-escalation of antibiotics, in fact, rather antibiotics, if at all they are needed, and stress ulcers prophylaxis. Maintain a good sugar level between say 150 to 180. The role of low molecular weight heparin, which should be considered after the third post-op day, especially in discussion with the neurosurgeon, and make sure that if it is contraindicated, then we need to actually institute the pneumatic compression devices. And we already discussed about the hypothermia, steroids definitely no, and neuroprotective treatment, which can be discussed. So I think this will give you a fair idea of what is going on and what was traumatic brain injury, especially in the light of brain trauma foundation guidelines. Thank you very much.
Thank you so much, Dr. Sarswati. It was a lovely lecture. We have a couple of questions for you.
Yeah, please.
We'd like to take those. So starting
I'll stop
off,
sharing.
Yeah, you can stop sharing the screen. So my first question is from Dr. Balakrishnan, who says, what are the chances of recovery from traumatic brain injury? And adding on to that question, he also says, how does TBI affect other vital organs apart from the brain?
Right. So if I understand correctly, there are two parts of this question. One is, how would we know that which traumatic brain injury will improve or not? So I think it is it's a very basic understanding that we need to understand what is a Glasgow Coma Scale of the patient who presents to us, what is the timing of the patient presenting to us, and of course whether there is any happening of the secondary injuries in in the form of hypoxia or hypotension. If you have a good GCS, if you have a correctable TBI, like for example extradural hematoma, undergoing surgery at a correct point, and then you taking care of the patient, which I actually shared a couple of slides about the standard ICU care which needs to be taken, I think they would have definitely a good prognosis. My understanding over the last, if I may correct you, that it has been now 20 years and not 18 years, because now I just finished about 1.5 years in my new hospital, that is the Medicover hospital. So in the last 20 years, I have realized that we need to be very aggressive as far as the traumatic brain injuries, or for that matter polytrauma patients, because essentially they're young patients. Most of them may not have any comorbidities. They have this likely possibility of a good response if you give them a good care at a correct time. The second part of the question was what are the different organs affected? So it depends whether the injury is only limited to the brain or it is a polytrauma. Then of course this is a very standard, it is a very it's a topic by itself. But I think I would say that a traumatic brain injury per se will affect 2-3 organs which I have actually shared. So it can have ARDS related to the treatment of traumatic brain injury. It can actually have coagulopathy, which I have shared. It can also have chances of renal failure if if the CPK is high. Again, it is a part of polytrauma or muscle injury. But essentially, I don't think we should actually think of any other injury apart from brain.
Okay. Thank you so much. My next question is from Dr. Amit Dhamankar, who says, how has stem cell therapy contributed to the advancement of TBI management?
Yeah. So again, if you really go on to see the Brain Trauma Foundation guidelines, there they don't have level 1 recommendation or even for that matter level 2 recommendation for stem cell therapy. It is still kind of I would say too early to comment upon, and probably not in the guidelines or a standard guidelines as of now.
Okay, sure. So I think you also talked about mannitol. So we have one question from Dr. Rajesh Velmurugan from KPS Hospital. He says, what is the role of mannitol with glycerine in TBI?
Yeah, so earlier probably it was, and if I can say so, because most of us who are into the practice have come from the government or the corporation hospitals, because obviously we take our postgraduate training from either of these hospitals. There we have this concept of giving or combining mannitol with glycerin. But again, as I kind of shared, the recent guidelines which actually doesn't talk of glycerin, and I don't think there is any role of glycerin in the treatment of traumatic brain injury.
Okay, sure. I hope it answers this question. And we've got two more questions. So these are mostly situation based. So a very rare condition seen most often in athletes is second impact syndrome, where an athlete sustains a second concussion event amid the continued recovery from an initial injury. So how can this be prevented by diagnosing the concussion initially?
To be very frank, I am not getting the question, because
Okay.
here the issue is, I think these things are pretty much clear. If the athlete is not well, and if he is being diagnosed as a case of concussion, I think they have a pretty much standard course, and they're not that serious or critical, as we see, as I discussed about the Glasgow coma scales of say 8 or 9. They would be obviously Glasgow coma scales of more than 8 or 9, whereas we know that less than 8 is bad and more than 8 is reasonably okay. So I can't answer the question probably. I don't know the
Okay.
answer.
Okay. Sure. One last thing. So, sir, as we see that a lot of referrals have to be done in such cases. So, what neurological exam should be done in suspected brain injury patients by the first point contact doctor, for like a general physician? And when should the referral to the specialist be needed?
Perfect. Now, this is a very basic, very good question. And someone has said that if the speaker says that it is a very good question, then probably he doesn't know the answer. But probably that is not the case, because the question is really very vital and very basic. So coming to the assessment of any suspected traumatic brain injury, as I said, the first and foremost thing, as we, the trainees or the intensivists or the neuro intensivists or anyone who works in a ER, needs to be very sure of the Glasgow coma scale, and and should be aware of how to assess the Glasgow coma scale. So it starts with Glasgow coma scale, wherein we take into consideration the eye response, the motor response. There is a best motor response and the best verbal response. So these are the three very important aspects of Glasgow coma scale, as we all know. Second is, of course, we need to see the pupil, the reactions of the pupil, whether they are unequal or they are equal, and whether they are reacting or they are not reacting. Number three, as I have already kind of shared in my talk, is about ABC. So any emergency, you need to have ABC. So you need to actually see whether the patient is breathing, whether the patient's airway is open. We need to be very careful and very vigilant in opening the airway with the modified jaw thrust, which I actually showed. We need to be sure of the oxygenation, delivery of oxygenation, the position of the patient if there is a suspected cervical spine injury, and of course circulation with the maintenance of mean blood pressure of more than 80. So I think these are the very simple things, but very important for the secondary outcome recovery.
So, sir, now these were the questions that I had. Any closing remarks or any comments for our budding, critical care specialists here, since you've been in the industry for more than 20 years now? So,
Yes.
anything you would want to tell them when it comes to TBI?
Okay, so I will start off by saying that it is only 20 years, so I'm not that old, but and everyone learns forever. And I think I always like that quote, and I like to quote it again, that you live as if you are to die tomorrow and learn as if you are to live forever. So even today and till the time we are kind of alive, we actually tend to learn each and every day. Having said that, I think I would say that don't restrict yourself to, I'm sure people would have that kind of affinity to call themselves as neurointensivists or cardiac intensivists or things like that. But I think because this is an era of speciality, But I think as a as a genuine doctor or a person who looks after the critically ill patients, we need to actually cater to all sorts of emergencies, and we should be able to do that. As far as traumatic brain injury is concerned, as I said, the majority of patients would be young. They would not have any comorbidities, and they would definitely do well if you follow the standard norms which have been taught to you, including the diffuse axonal injuries. We time and again see that the scan is very bad on day 1 or day 2 or day 5, but then eventually if you just maintain them, they may do well. So even one life saved would fetch us so many other things, and that is why we live for.
Of course. I think with this note, with this positive note, I would like to end today's session. Thank you so much, Dr. Sahasrabuddev. It was lovely having you here. And especially the points which you made around, especially the general surgeons, because we also see a lot of budding critical care specialists or surgeons watching the program here. So I think it would be ideal for them as well. So thank you so much. Thank you so much for your time, sir.
Thank you very much.
Have a great evening.
Yeah, and thanks to your team. Thanks to you and your team.
Sure.
Yeah.
Thank you so much. Have a good evening, sir. Bye-bye.